Great. I am Dr. Lisa Isaac, President of Gateway Medical Society. Welcome to the program today. Gateway was established in Pittsburgh in 1963 as a component of the National Medical Association. Our mission is to eradicate healthcare disparities. We do this by providing education to promote public health, raising awareness of the healthcare disparities in minority and disadvantaged communities, and collaborating with other groups who have similar missions. It is therefore my pleasure to welcome you today to our annual Community Symposium. And yes, this is our second virtual Community Symposium. Having gone virtual for the first time a year ago, I don't think any of us thought that we would be virtual again this year. Yet here we are. In this in this era of COVID-19, we just have to continually adjust, so we move forward. This year, we have decided to replace our day-long symposium with monthly hour-long segments dealing with various topics. There will be about 7 of these from now through the end of the year. Today, we are teaming up with the Pittsburgh Black Nurses in Action on the topic of maternal child health resources. We have assembled a distinguished panel with a moderator and speakers who are truly knowledgeable on the subject. I'm certain your participation today will give you valuable information. Now, whether you are new to our community symposium or someone who's participated for years, I welcome you and I thank you for your participation today. Before we continue, I would like to take a moment to thank our symposium partners, and that's including the Heinz Endowments, Highmark, UPMC, the Links Incorporated, Gateway Health, Pittsburgh Black Nurses in Action, my sisters at Alpha Kappa Alpha Sorority Incorporated, Alpha Alpha Omega Chapter, and the Ivy Charitable Endowment Incorporated. And really, I'd just like to thank anyone that has helped us with this endeavor. So now at this time, I would like to present our moderator, Dr. Dondra Jones. Dr. Dondra Jones has been with UPMC for over 30 years, working in multiple positions, spanning from staff nurse to various nursing leadership and executive positions. She has recently been named to the position of Vice President of Patient Care Services and Chief Nursing Officer of UPMC McGee Women's Hospital, having previously served as the CNO at UPMC East and UPMC McKeesport Hospitals. Dr. Jones received her bachelor's and master's degree in nursing from Carlow University and a doctor of nursing practice in nursing administration with a minor in nursing informatics from the University of Pittsburgh School of Nursing. She also holds a nurse executive advanced certification from the American Nurse Credentialing Center. Currently, she serves on multiple federal and state councils and committees. She serves on several board of directors for various organizations and is the immediate past president of the Pittsburgh Black Nurses in Action, the local chapter of the National Black Nurses Association. Dr. Jones has received numerous awards, including the Pennsylvania Nightingale Award in the CNO executive category. She was ranked 23rd by Talk Magazine's 100 Most Influential African-American Pennsylvanians. And in 2019, she was recognized by the Pittsburgh Courier with a Women of Excellence Award and by Pittsburgh Magazine with the Nursing Excellence in Leadership Awards. Dr. Jones, we do thank you for being with us today and joining us as the moderator of our program. So as we move forward, would you introduce the other members of the panel, our speakers, and then just take it away?
Absolutely. So thank you. I want to make sure you can hear me okay, Dr. Isaac?
Yes, I can.
Perfect. Well, I want to thank you for such a warm welcome and introduction. I actually also have to thank Gateway Medical Society for such a strong partnership that you have had with Pittsburgh Black Nurses in Action, because we know it takes the entire healthcare team, our physicians, our nurses, and all of our ancillary support. working together to improve the health and wellness of our communities. I am excited for this event today, and over the next hour, we will be sharing and really helping to improve the health status of our community. I have 3 objectives that we're hoping to achieve today. First, we will have an overview of data and findings related to maternal health within the Pennsylvania, as well as we will be learning from our Commonwealth of Pennsylvania's Maternal Mortality Review Committee, as well as Healthy Start, and what they're doing to help to address these health disparities in this area. And then lastly, we want to learn about community engagement, about the resources available, as well as what we all can do to improve the health and wellness of our loved ones when it comes to maternal and child health. And with that, I know we have 2 excellent panelists that will help us to achieve these outcomes today. The first is Dr. Betty Braxter. Dr. Betty Braxter is the Associate Dean of the Undergraduate Education Program and Associate Professor of the University of Pittsburgh School of Nursing. She is a graduate of Louisiana State University Medical Center, where she received her BSN. She's also then got her master's from Texas Women's Health University. And she received her PhD in nursing, at the University of Pittsburgh. And she attended the University of Mississippi Medical Center Nurse Midwifery Program. She has worked many years with junior level pre-licensure students enrolled in the mother-baby nursing course at the School of Nursing at the University of Pittsburgh. She continues to teach in the School of Nursing's Nurse Midwifery Program. Her research interests include tobacco use among childbearing individuals and health disparities, including a specific focus on maternal mortality and morbidity. Her clinical interests are aligned with her work as a certified nurse midwife with a focus on providing care to childbearing age individuals across the lifespan. She's a member of Pittsburgh Black Nurses in Action and Kappa chapter of Chi Eta Phi Nursing Sorority. She has served as co-chair of the Women's Health Committee of the National Black Nurses Association. She serves on the Commonwealth of Pennsylvania Maternal Mortality Review Committee. Our second speaker is Ms. Jada Sherrill, who is the Chief Executive Officer of Healthy Start Incorporated, a public health organization that focuses on improving maternal and child health and addressing the disparities that lead to higher rates in infant and maternal mortality among Black women. With 18 years of nonprofit development, public involvement, and project management experience, Jada's niche areas are fundraising and focusing on collaborative processes that result in greater efficiencies, synergistic relationship, and defined outcomes that lead to community-level change. In her 5 years in leadership at Healthy Start, Jada has deepened the organization's focus and impact on community-level advocacy, system-level coordination, and elevating the voices of women served. In her role at Healthy Start and related community work, Jada strives to ensure that health equity remains at the forefront of all conversations. Jada is a certified human-centered design practitioner, is trained in strategic doing, and is a certified lactation counselor. She is an undergraduate of the H. Heinz II College at Carnegie Mellon University and the Earl Graves School of Business and Management at Morgan State University. Jada is the owner of J. Sherrill Consulting. Jada is the mother of 3 sons and in her spare time enjoys reading, traveling, and spending time with her family and friends. And so we're going to begin our presentations today with Dr. Betty Braxter sharing the role of the Commonwealth of PA's Maternal Mortality Review Committee. Please, as you all are listening to her presentation, and if you have questions, please you can submit those in the chat. We will address all questions at the end of our second presentation from our second panelist. And so without further ado, I turn this over to Dr. Betty Braxter.
Thank you, Dr. Jones. Will you please share my slides? Thank you so much. Good morning, all. I can't say I'm delighted to be here. I'm delighted to be among friends and to talk about improving the health and well-being of all birthing persons, particularly African-American women in terms of maternal health. And when we speak of maternal mortality, this is something that I hope in the future that we will not need to have this type of discussion, that we will have turned the corner. Will you, next slide, please. So the purpose for the next couple of minutes, I want to share with all the role of a maternal mortality review committee. And I'm going to refer to the committee as the MMRC. Next slide, please. Many of you have seen these alarming statistics. And every other week, you may see either on TV or mass media, or as you're browsing the internet, the number 700. That represents the number of women or birthing persons who died due to a pregnancy or delivery-related complication. Now, most of the deaths are among women age 40 and over. However, even most alarming is the idea that 40%, and others say 60 to 70% of the deaths are preventable. So if we use 70% as our guideline of that 700 number, 490 women could have been saved. That's the immensity of this particular problem. Unfortunately, Black women are 2.5 times more likely compared to white women to die. Now, the number 700 fluctuates according to the resources, according to the entity that is evaluating the data. As recently as 2019, 2020, the National Center for Health Statistics reported that about 749 women had died in 2019. Next slide, please. This is the definition of maternal deaths. It's a death during pregnancy or within 42 days after the end of the pregnancy. And the most important areas to focus on in terms of this definition is that's irrespective of the duration of the pregnancy. It's irrespective of where the pregnancy is located. And it also is associated with a cause that was related to the pregnancy that worsened during the pregnancy or the management of that pregnancy. So this idea of maternal death really extends across the whole pregnancy period and even before. Next slide, please. Just wanted to give you a sense and kind of bring to your mind we talk about the numbers, but here are the faces of some of the women who died in 2016. This was a series that was published in the New York Times. Some of you listening probably read about this series. It's called the Lost Mothers series. Several reporters got together and actually interviewed the families of these women. For every circle you see on this slide, that circle represents a woman who died during 2016. And the reporters were able to identify or reach out to 134 families because their report focused and spotlighted the 134 women who had died. So it's not just the numbers, it's the implication of those deaths related to the families, related to the children of those individuals who died. Next slide, please. Next, thank you so much. The MMRC is composed of many different individuals: obstetrician, gynecologist, addiction medicine individuals, family medicine individuals, epidemiologist, forensic pathologist, psychologist, nurses, nurse midwives, members of organizations such as Ms. Sherelle is involved in, and the best of the MMRCs are also composed of families who have experienced a maternal death. And the key function of the committee, irrespective of the state or the location, is to answer the question, was the death related to pregnancy? And that is the key question. Was the death related to pregnancy? And after that determination is made, which is often very difficult to make that determination, given there are so many factors you have to review. After that determination is made, then follow-up questions are asked. The committee receives a form called the MRC form. It's the Maternal Mortality Review Information Application Form. And that form has a list of questions that need to be responded to after the determination, yes, the death was related or not related. For the Maternal Mortality Review Committees, typically here in the States, we think of the death as being 1 year post the end of the pregnancy. So the 42 days is a part of the definition of the World Health Organization. The actual implementation and actions of the MMRC looks at maternal death across the pregnancy through the postpartum period until 1 year following the pregnancy. Next slide, please. So if the determination is the pregnancy was, the death is pregnancy related, after review of the data, review of the information provided, there are 5 other questions that need to be addressed. What was the underlying cause? Most frequent underlying causes here in the States occur as a result of a cardiovascular problem. It could be cardiomyopathy, where the heart muscle is damaged and the heart is not functioning well and not pumping enough blood. It could be a thrombus or a clot, such as a pulmonary emboli. Those are the most frequent causes of death here in the US. When we look at Black women, again, it's the cardiovascular type of diseases that result in death for Black women. After trying to identify a cause, then the key question becomes, was that death preventable? And there are factors that the committee looks at in terms of prevention. Look at the family, the individual, the provider, the person who is trained to provide the care. Look at the system where the care was delivered. They also look at the neighborhood or the community at large. So these are some areas that we focus on in terms of identifying factors associated potentially with the underlying cause. Next slide, please. What are factors contributing? So we look at underlying causes and other factors contributing. And these factors can include interpersonal racism, adherence, transportation, a number of factors associated with child care, those kind of things. So we begin to kind of narrow it down. Yes, it was pregnancy related. What are the causes? What are the factors? And the factors are important because you want to address the factors. And I think the most salient component of the MMRC, that is the development of recommendations. What are the recommendations that can be implemented that can help to or eliminate the factor that caused the death of that person? And again, the committee comes together with all the individuals around thinking of ways that can be put in place so that we can have a better outcome. And what are the expected impact of those recommendations. Is it a small effect? Is it a moderate effect? Is it a gigantic effect that could be across the state or across just a city or within a region? So these are the basic questions associated with the Maternal Mortality Review Committee function. The function of the committee is to develop recommendations to reduce maternal mortality. Next slide, please. Maternal mortality review committees have been in existence in this country for more than 12 years. One of the first maternal mortality review committees that I've seen in the literature was established around 2008. The Commonwealth of Pennsylvania established a statewide maternal mortality review committee in 2018. And that committee has been meeting initially after the first initial meeting. We were meeting after a couple of months in order to kind of get ourselves together to determine how we want to function. We had some documents that provided a format and gave us a pathway for functioning. One was a review referred to as the 9-committee Maternal Mortality Review Committee report. That was published in 2017. And the committee report were comprised of several states, including Ohio, Colorado. They had functioned. They had been holding community MMRCs in their respective states for more than 10 years. As to the format, how to deal with some of the issues that occur as you're moving through the MMRC. What has been found with MMRC is that they do make a difference. Now, Philadelphia, the city of Philadelphia established their MMRC on a city level in 2010. Prior to the establishment of the MMRC in Philadelphia, their death rate was like 27.4 deaths per 100,000 live births. And that was at the zenith, or the highest rate that had been found. And that was between 2010, 2013. After the establishment of the MRC and other factors, it's just not the MMRC. The most recent death rate for Philadelphia was like 20.7 per 100,000. So you can see in the reduction in the rate with the MMRC, other initiatives occurring, that they were able to reduce the death rate. And that is typically the findings associated with implementation of MMRCs, that they do make a difference. Next slide, please. So the question now becomes, and this is kind of a call to action question, what can you do? And I divided it into 2 slides. This first slide really addresses if you are a birthing person or a family member of a birthing person or a woman. First thing within the family you can do is know your family history. Know what it is. Is your family, moms, sisters, grandmothers, did they have low birth rate infants? Did they have preterm infants? Were they more likely to have surgical procedures associated with their delivery? That is a family, that's talk that can occur within families. The next is to know warning signs, and I'll talk about the warning signs in just a minute or two because I know my time is running toward the end. The next is modify behaviors prior to the pregnancy. And this is called a part of preconception counseling. Here in the States, we do a very good job in terms of talking about preventing sexual accidents, targeting adolescent pregnancy, talking about, backup family planning. We don't do as well a job talking about preconception counseling. It has nothing to do in terms of sex itself. but how do we have healthy bodies in order to have healthy families? So begin to modify your behaviors. If you are someone who enjoys caffeine quite a bit and you find that you drink 10 to 12 cups of caffeinated coffee, as you plan to become pregnant, begin to taper your caffeinated intake. Then I want to really put in a plug for vaccinations. Sometimes in some communities that has become a very politicized and polarizing word. Vaccinations work. Flu vaccines, get those. We know that moms who don't get flu vaccines, when they become pregnant, there is increased risk for adverse outcomes like preterm deliveries. Tdap, if your provider offers that, get Tdap. The provider may offer it after the 27th week of your pregnancy, between the 27th and 36th week. And lest I forget, really think about getting the COVID-19 vaccine. We don't see in the data so far that within the maternal arena, we've had enormous deaths so far. We don't know what the implications are. So vaccinations do work. And then talk with your healthcare providers, the nurses, nurse midwives, the physicians about your concerns as relates to maternal health, about your expectations in the care you receive. We'll talk a little bit more about that because I want to plug a legislative act that's coming about. But these are actions that, as individuals who are making the decision whether or not to become pregnant, these are actions that all family members can take also. Now let's look at slide 2. Next slide, please. What can all of us do? Number one, if asked, we should really consider serving on an MMRC committee. One of the initiatives that is here in the Pittsburgh area, as well as across the nation, is called our Perinatal Quality Collaborative. It's a number of individuals getting together, physicians, nurses, individual members of organizations working within the maternal health space, getting together, talking about what is happening during the pregnancy. And one of the best examples of a good perinatal quality collaborative is having members who have family members and members living in the neighborhood and communities who've experienced something like a severe maternal mortality, maternal morbidity experience. It will be emotional, but we need families at the table also. Know the warning signs. I've said that twice. Advocate, and I strongly advise you to look at what is known as the Black Maternal Health Omnibus Act. It's an act that was originally submitted in the Senate by our now Vice President Kamala Harris. That act has been continued to move forward into 2021. Representative Lauren Underwood from Illinois is sponsoring the House Bill 959. Senator Cory Booker is sponsoring Senate Bill 346. Why is that important to all of us on this, listening to this presentation and listening to this Gateway and PBNIA synergistic teaming together to talk about maternal health? Because part of that act talks about diversifying the workforce within the maternal health space. Part of that act talks about expanding nutritional supplementation for WIC. Part of that act really goes to the core of trying to reduce maternal mortality and maternal morbidity among African Americans, Hispanic, First Nation women. So this act is important to get through and to get implemented. We believe the president will sign it. We just have to get it through the House of Representatives and the Senate. If you're interested in understanding the implementation of this act for Allegheny County and the city of Pittsburgh, Global WHAM has developed a brochure that talks about what Omnibus Act means for the city of Pittsburgh and Allegheny County. You might want to review it. Next slide, please. My final minute or two. These are warning signs that all of us should be aware of. And it begins with pregnant now or within the last year. Headache that is so bad. Often moms say, this is the worst headache I've ever had. Kind of dizziness, blurring, spots before the eyes, high fever, as you can see. Edema or swelling of the hands, particularly that the woman can't put on rings. Thoughts of hurting self or baby. Not being able to breathe, chest pains. Then, abdominal pains, any bleeding, any fluid, really cramps and redness, particularly of the lower extremities. All of our excessive sleeping or not feeling the baby move. These are signs that we all need to be aware of. And when these signs occur, we need to take action. One of the points on the previous slide referred to what is called Hear Her. Hear Her is an initiative from the CDC, and it talks about listening to women who are pregnant. So if they share with any of us, any of these signs, we should listen to that woman, get her to a healthcare provider as soon as possible, and support her through it. Final slide, please. This is another format for warning signs, and I like it because it has a mnemonic so that people like me can think about post-birth. What is interesting is that we often think of the deaths occurring with labor and delivery. Yes, that's about 36% of the deaths. 33% occur during the pregnancy. And according to the National Center for Health Statistics, about 34% occurred during the postpartum period that can extend 1 year out post-delivery. So when we think about those deaths occurring after delivery, pain in the chest, obstructed breathing, seizures, thoughts of hurting self or baby, bleeding, incisions that are red and not healing, red and swollen legs, temperature, headaches that just don't go away. All of us can, if thinking of warning signs, thinking of the Omnibus Act, all of us can participate. Reach out to your senator, reach out to your representative, and let them know if they've supported the act, compliment them, thank them. If they haven't, share your thoughts and concerns, because today, this very day, 1 to 2 women will die as a result of a pregnancy-related complication. I hope I finished in time. I will yield it back to the moderator.
Thank you, Dr. Braxter, for your very passionate presentation. And I know that our participants have truly learned a lot from what you have shared with us today. Next, I'm excited to introduce and bring to the presentation Ms. Jada Sherrill. Remember, though, everyone who is participating, please, if you have questions, you can start entering them in the chat during Ms. Sherrill's presentation, and we will make sure that we get to all questions at the end of her presentation. So with that, I turn it over to you, Ms. Sherrill.
Thank you. Good morning, everyone. Thank you for the opportunity to talk about Healthy Start. And really, Dr. Braxter's presentation was a great setup to me telling you all what Healthy Start is doing to address some of these disparities and pressing health issues. Can you share my presentation, please? Thank you. Okay, so my objectives for today are to discuss with you all the relevance of community-based maternal and child health programs and interventions, to describe the programs and services that Healthy Start offers, and make sure that you all know how to refer to Healthy Start. Next slide, please. So as Dr. Braxter laid out pretty clearly based on her work, both clinically, her day-to-day work and her work on the Maternal Mortality Review Committee, we are in a state of crisis as it relates to both infant and maternal death. I think as society, we've long understood that infant mortality is a huge issue, but as of late, we've begun to pay better attention to maternal health and what is going on with mom as it relates to her health, both prenatally and postpartum. There's been a plethora of recent media that has highlighted this issue nationally, and it's been brought to national attention as a crisis. Dr. Braxter did mention the Lost Mothers series. Healthy Start actually hosted one of the reporters from the Lost Mothers series from ProPublica, Adriana Gallardo, at our annual symposium in 2018. And one of the things that she said that stuck with me is that this has gone from a private tragedy to a public crisis. So long gone are the days that we have women sit in silence about their loss, or have families sit in silence about the loss of the matriarch of their household. We need to all accept that this is a failure for us as a society and do something about it. Next slide, please. So also putting in context the work that Healthy Start does is really, quite frankly, how Pittsburgh is failing Black women. So I think we're all aware of the Gender Equity Commission report that was released in 2019. And although that very valid, very timely, very important data came out of that study, there were some glaring omissions, and some of us who are working in this space felt that there was a lack of the voice of Black women in that report. And so the report covered a myriad of topics in the intersection of health, economic status, education. But one of the things that really rose to the top was what's going on with Black women and our health, what's going on with our babies. And so we really saw the need to speak out about that process because the report does continue to be talked about. And, it's great that we're having these conversations, but part of Healthy Start's mission is to also make sure that the voices of Black women are elevated from A to Z. So that means in conducting research and in how we serve our communities and in the resources that are put on the table to do that work. If you are interested, NPR did cover a series of meetings and convenings in response to the report, and you can follow that link that's on this slide and see the response to the report that was penned by about 20 Black women working in the city of Pittsburgh and Allegheny County. Next slide, please. So the context for our work, again, is about elevating the voices of Black women because we have the solutions if folks would just listen to us. But the context is also about this quote from the National Academy of Medicine: as a determinant of health, medical care is insufficient for ensuring better health outcomes. So the importance of community-based interventions is really to make sure that there is adequate support in community to address the social determinants of health and to address what goes on in our day-to-day. Most of us don't spend a good amount of time with our doctors. We go when we need preventative care, hopefully, and we go when something's wrong. And hopefully we're in a place to take those directives and make changes. But a lot of folks are not in a place to take the directives of their medical care providers and make changes. And it's because of what goes on in their day-to-day community environments. So Healthy Start is really here to make sure that we are filling the gap and ensuring that women and families and community can be healthy and are in a place to communicate and access their health care and do that successfully. Next slide. So what does our array of services look like? So I think a lot of folks know Healthy Start as a home visiting program. We work with women who are pregnant, and then we work with them as they give birth and as they are beginning the stages of raising their children. We've been in the community for 30 years. I was in the program 19 years ago. So the mission of Healthy Start is really near and dear to me. So that's the direct service piece. I think what may be new information is all of the other things that we do. So we do a lot of collaborating and convening for collective impact. So our collective impact model really means that Healthy Start can't do this work alone. Doctors and nurses and hospital institutions can't do this work alone. So how do we all work together from government, our health department, to community-based organizations like Healthy Start and so many others, to community-based birth workers? How do we work together, our research and academic community, and really collectively share the same goals and push this issue forward? Policy and advocacy. So Dr. Braxter mentioned the Omnibus Act, the Black Maternal Health Omnibus Act, and shout out to Morgan Overton for putting together a wonderful briefing on behalf of the Jewish Healthcare Foundation for that act. I do encourage everyone to take a look and see how you can get involved in promoting that, because it will be pivotal legislation to give us the resources that we need to address these issues. So we are very much involved in advocacy. We send staff and community members to Harrisburg when we can to advocate. A few years ago, we hosted a Black Maternal Mental Health Summit with Ed Gainey and Gateway Health, and we are doing a lot in the space of research. It's really important that we are participating in research, and it's also important at the same time that we're critical at what that research looks like. So some of the things that we do at Healthy Start is to make sure that we are involved in research at phase 1 in the design of the research. We are listed as co-PIs on research. We are engaging other Black women in our network to help shape out research questions and research design. Because what doesn't work is when the research is already shaped out, it's already designed, and it doesn't meet our needs, but then folks are reaching out to Healthy Start, and I'm sure a plethora of other organizations, and want Black women and families to participate in research that never really had our involvement from the beginning. Next slide, please. So our programs and services, we have a plethora of programs and services. I'm going to kind of dig a little deeper because I really want to make sure that you all understand the breadth of what we do so that you can be involved in it, you can support it. And one thing I think is really important to note is that our direct service offerings to the community are not income-based. We do not serve an exclusive Medicaid population. We do not serve an exclusive low socioeconomic status population. For Black women in our maternal and child health disparities, income and education is not a protective factor. So I can't overstate, how many times people think, oh, I'm not going to sign up for, a Black pregnant woman in Pittsburgh who might be well educated and might be comfortable in her economic status, doesn't think that this program is for her. And that couldn't be more wrong. That education and that economic status does not protect us against racism. It does not protect us against bias in healthcare. It does not protect us against the historical impact and implication of our medical system that was designed to exploit us. Next slide, please. So first I have to say, we can't do this work without a fantastic multidisciplinary team. Our team includes peer professionals, lactation counselors, doulas. We contract with community-based birth workers that have their own company. We have social workers, we have master's level clinicians, we have mental health interventionalists, we have public health professionals. We have some staff who have been with the organization for 20+ years, and then we have some newer staff that really just want to be in a space of making an impact. And so it's really important to highlight the work of our team. I'm very proud and thankful for our team and can't do this work without them. They're dedicated. And again, our mission is really focused on the Black-white disparity. So health equity is at the forefront of the minds of all of our staff, whether they're Black, white, or any other nationality or ethnic origin. We look to have a workplace as well as programming that's inclusive to all identities. So we have a lot of diversity on our team in that respect as well. Next slide, please. So just to kind of give you an overview, and this is a really quick overview of our services, and please reach out to me if you have an organization or an individual that would like more information, because it's a lot. So we offer prenatal and postpartum home visiting. And so what that means is the home visiting is really the modality that we typically like to meet our families where they are. That can mean in their residence, but it can also mean somewhere else in their community. Our goal is to eliminate eliminate barriers to seeking care. So we don't have a center where folks have to come to us in order to be seen and heard and to get the support that they need. We go to them. We enroll women prenatally because, again, our goal is to impact their birth outcomes. We have fantastic outcomes against the norm, particularly for the population that we serve. And even though we serve a small subset of birthing people in Allegheny County, that small subset is highly impacted. We have not had any infant deaths in the past year, and we have very few preterm births. We offer centering pregnancy, so that is an evidence-based group prenatal care model. We do that in conjunction with primary services. So I think most well known for Alma Illery, we partner with them. And again, it's our commitment to community. We want to make sure that our community members are taking advantage of their community-based healthcare centers. We offer childbirth education, mental health support. So again, we have an evidence-based program called Moving Beyond Depression. It is an in-home intervention. So again, removing the barrier of moms having to go to a mental health therapist, particularly immediately before she delivers and immediately postpartum, where there's a lot going on. There may be a lack of motivation. There may be transportation or childcare barriers. Our goal with this program is to immediately address the depressive symptoms. And if further aftercare is needed, we absolutely want moms to be connected to a community mental health clinician. But sometimes making that initial connection and reducing the barrier there is really important. We offer lactation support. We have the Healthy Start Center for Urban Breastfeeding, which we were able to pilot with support from the Highmark Foundation, and that has been an astronomical success. We offer on-demand 24/7 around-the-clock postpartum breastfeeding support to new moms so that they do not give up on their breastfeeding journey because it's hard. We also offer phone and video support, again, around the clock. And our focus, again, is Black women. We have a doula program. We started that doula program during the pandemic, and it has grown. Right now, we are transitioning from a virtual modality. And hopefully, if this pandemic will go away, we can get back into being more in the hospital setting and physical contact with our moms. We have a fatherhood support program. And so, you know, the federal government, who has historically funded us, is very intentional about fatherhood support because it is a protective factor, but we actually support whoever mom has in her life. Whoever it is that is supporting her, that's who we support. We do a lot with adolescent health, and we have a sexual risk avoidance education program called Teen Outreach Program, and that is an evidence-based program, and community education. It's important that not only are we supporting and uplifting our moms, but that we're supporting and uplifting the entire community so that mom does not have an uphill battle as it relates to the things that she wants to do around her prenatal and postpartum care. Next slide, please. So we have a program called Community Health Advocates, and it's kind of under our advocacy and community education, but it's really also a way to give back and a way to continue to elevate the voices of Black women. So we started this with the health department, I think now maybe 3 or 4 years ago. We've graduated over 50 women from this program. We've had support from Gateway Health, from Eden Hall Foundation, from Hines, and a plethora of other funders who really invest in the capacity of Black women. And what this is, it's a cohort model, about 12 weeks. We train women who already have some interest in community health on public health, health equity, advocacy, and connect them with leadership opportunities in their community. Some of those folks we have hired at Healthy Start. We have supported them in furthering their workforce development goals in the space of birth work. So we've sponsorship some of them to be lactation counselors, doulas, and supported other endeavors. Next slide, please. Oh. maybe click it one more time. I think maybe the pictures will come up. Okay, there we go. You might have to keep clicking. Thank you. Sorry about that. One of the other things that's really important to us is investing in our workforce pipeline. So we have a really dynamic and dedicated and passionate Black birth worker community in Pittsburgh. Sometimes I don't think we get enough respect in Pittsburgh, but that's okay. We're working on that. But we think it's really important to support our Black birth workers who want to continue to impact their communities. So we contract with a lot of folks who are doing this work, maybe have their own companies, who are doing this work and underpaid and overburdened, and making sure that they have a platform, and that we also continue to grow the pipeline of Black birth workers so that we can be for us, by us. We get a lot of feedback from our moms that they want Black providers. They feel more heard. They feel that it's easier to really talk about what's going on with them. And it's sometimes easier to break down the health information that's shared when you have someone that speaks a common language. Next slide, please. Collective impact. So this is just an example of one of our collective impact projects. We have so many. So the folks on this slide include Healthy Start staff, Dr. Dara Mendez from Pitt, Danae Wilson from the Health Department, Alicia Davis, who is now at March of Dimes, Amy from the Department of Human Services, and one of our intern fellows from Pitt, and then Dr. Vijaya Hogan, who is a national health equity leader. We got together and began brainstorming with support from the Forbes funds on how can we really move forward a collective impact approach to reducing infant and maternal mortality and improving health equity for Black women in Allegheny County. And it's really a long range effort and initiative, and we will continue to grow it. But our initial conversations focused on equity analysis using the R4P model that Dr. Hogan created, as well as looking at how are stakeholders that are working in the space of maternal and child health in Allegheny County connected. And we did a power and equity analysis. And so I think we hope to do a public unveiling of our initial work before the end of 2021, but just highlighting and underscoring the importance of not doing this work alone. We cannot do it alone. It takes a multi-sector approach. And really that approach hopefully trickles down to the work that we do directly in community. Next slide. Another example of collective impact approach is the Best Baby Zone model, which is a national model of place-based and community-based reduction of infant mortality. And so Healthy Start and the Health Department, again, partner to, for one, reduce the number of working groups that were working on the same thing. So the Health Department had their Infant Mortality Committee, and then there were several other committees that were convening. So we all got together, kind of consolidated, and got some support from AmChip and City Match, and created the Best Equity Institute, and BEST is an acronym. And our Healthy Baby Zone work that's being done in Wilkinsburg includes partners such as Pitt, Circles Greater Pittsburgh, which is now Catapult. Okra Ethics has served as a consultant to the work. Of course, the Health Department, again, Women for a Healthier Environment, and Trying Together. And with this model, we engaged a community champion. So that is a community member who is dedicated to this project, but serves as a go-between between the institutions and the people that kind of do this as a 9-to-5, making sure that we are responsive to the needs of the community and that we have a really strong community connection. Next slide, please. In the space of advocacy, our Community Action Network, which is an entity that Healthy Start has that, again, keeps us connected and accountable to community, hosted a legislative breakfast earlier this year. Our keynote was Representative Morgan Cephas, and we had lots of our local legislators in attendance. And we put this on in collaboration with the Black Women's Policy Agenda. So again, we are working diligently in the space of advocacy. We talked a lot about the Black Maternal Health Omnibus, and just underscoring again that we can't do this work alone. Next slide. Research. So we are involved in a number of research studies, one being the Pittsburgh study, and really making sure that we try to help keep equity at the forefront and keep community involvement at the forefront of that project. I'm one of the co-leads for the Pregnancy Collaborative. And then we also have a long-range project with McGee Women's Research Institute looking at cardiovascular risk and what interventions can be clinically and community partnered that reduce cardiovascular risk for those most impacted. We've continued to leverage trusted community voices in the work that we do. And I think we've really made a lot of strides in really impacting some of our local researchers to reconsider what community engaged research looks like to them. Next slide, please. So how do you refer to Healthy Start? Again, I want to underscore that we do not have income criteria for our services. About 75 to 80% of the families and the women we serve are Black. The rest identify as white and lots of other ethnicities. We do serve non-English speaking families as well. Our website contains a plethora of information as well as how to reach us and how to refer. There is an online referral form on our website if you go under the home visiting tab and then enrollment. And so if you know of anyone who you think could benefit from any of our services or know someone who wants to enroll, that would be the first point of contact for them. The Healthy Start Center for Urban Breastfeeding, because it is an on-demand service, we have an on-call line. So if you know someone who has just given birth and needs support or needs a little bit of help, even if it's just an issue latching or a longer term issue, they can call our on-call line or email us. We also encourage women to start exploring their breastfeeding goals prenatally, not waiting until after they have the baby, because as some of us know, it can be hard to get support in the hospital. And then you can contact our main office if you need to speak to a live person during business hours or have any questions about our programs. Please join our mailing list, which you can do via our website, and follow us on social media. We do send out a monthly newsletter, and sometimes we have intermittent announcements before the monthly newsletter comes out. And a lot of that also is posted on our social media. Also want to highlight that August is National Breastfeeding Month, and Black Breastfeeding Week happens during the last week of that month. So we have lots of exciting things planned for August in conjunction with the Pittsburgh Black Breastfeeding Circle, as well as the Safer Childbirth Cities Committee, which is part of the Mmrc for Mothers initiative that is housed under the Jewish Healthcare Foundation that we have a community engagement portion of. That's it for me. I appreciate this opportunity yet again, and for all of those funders and partners who have supported our evolution as an organization so that we can continue to meet the real-time needs of families in Allegheny County. Thank you.
Thank you, Ms. Sherelle, for your awesome presentation and sharing with us the work that is happening through Healthy Start. We greatly appreciate your participation today. And so I know we're getting close to that 12 o'clock hour, but I do have a couple of questions that I think we would love to have our panelists to address. And so the first one is really surrounding how do we help support individuals as we're hearing a lot about this information, I think, and as a representative of the hospitals, what I'm finding is that we have our African-American women coming into the hospitals for delivery, and many of them are coming in scared. They know the data. We've seen it through, various initiatives, and we're hearing about it. And they're truly scared, and they're worried about what's going to happen to me during my delivery process or maybe even post-delivery. And so my question to you all is, how can we better support these individuals in lessening their anxiety during their pregnancy as well as delivery and post-delivery?
I'll start, because I think one of the initiatives, Hear Me, is an initiative that we can implement, and some people have implemented, to take the time to listen to the individuals and to respond to them. Often individuals will come in, and it's quite true, Dr. Jones, women now know what the data is telling them. And irrespective of what others say, they know this data. And so I think Hear Me is a good way of stop, turn around, look at the individuals. There's been enough data in the implicit bias arena to suggest there are some differences in how, even within the same facility, by the same providers, there are differences in terms of those interactions. So I think that is one opportunity for all of us, and to support these women and their families as they move through. I think this is the right way to go, and to try to lessen the anxiety. And I will share with you, if facilities were more transparent, if they even put their C-section rate up so that people can look at that, or their preterm birth rate up, I think some women would say, well, they're trying to provide us with information on where they're standing. These are simple, non-financial based actions that facilities and systems can do.
Thank you, Dr. Braxter. Ms. Sherrill, would you like to add to that?
Yes, thank you. I would just add to that I agree that women now know the data, and behind every data point is an actual person. And so women are coming into the hospital setting, not only knowing the data, but also having their own previous and a lot of times traumatic experiences. And so I think just being aware of that, and having had a baby within the last year and doing this work and kind of thinking about how this all comes together, I can imagine how hectic it is in the hospital setting for nurses, doctors, everyone. But at the same time, each one person doesn't care about any of that. They care about their experience, their health. Are they safe? Do they feel heard? And I realize it can be hard to bridge that gap between checking off the box of things to do today, the patient that's down the hall, the one that's in, room 105, 106, 107, but just taking the time to acknowledge and affirm what someone says their experience was, no matter how outlandish it may seem, no matter if you've never heard that before, no matter if you think it sounds ridiculous, that's their experience and that's their concern, and genuinely affirming it. In my experience, I had the housekeeper, Black woman. She came and, "Are you okay, sis? Do you have what you need?" as she was cleaning the bathroom. Those are the experiences that those are the connections that you get when you are among someone who has a shared experience. And she, I'm sure, knows how Black women are treated in these institutions. So just taking the time to make sure that you are affirming and really hearing what's being said and not dismissing people. I think that's the short range goal. The long range goal involves a lot of other work, but in the short term, just acknowledging and affirming the feedback that's being given.
Okay, no, thank you for that from both of you. I can share with you that at Magee Women's Hospital, we do take this very seriously. We have added doulas to our healthcare team. We just had a graduation recently of a new set of doulas to add to our team, so we're excited about that. If someone is interested, they can get just-in-time doula as well when they get admitted to the hospital. And we have that resource through the Birth Circle doulas at upmc.edu. And Ms. Sherrill, I know there's doulas availability through Healthy Start as well. Can you share with those participating, what is the role of the doula, as well as what are some of those qualifications people should be looking at, as we now have various ways of getting a doula?
Absolutely. And so we are partnering with the team at Magee to help expand the availability of doulas to all women. And I'd like to think that the nagging voices of myself and our staff have really helped folks to see how important this issue is. We have several trained doulas and certified doulas at Healthy Start, and I learned from them. I'm not a doula, but I've learned a lot over the past year in supporting our Director of Strategic Initiatives, Demia, in launching our doula program. And I think that there are so many different options for doula support out there. Like I said, there's Magee's doulas, there's Healthy Start, there's lots of women who have private practice doulas, there's women who have specialty practice if you want some crystals and some sage with your doula, if you want a doula that's a bit more, whatever, there's a plethora. So I think the first is understanding what a doula does, non-clinical birth support. A doula is a part of your care team. You can still have your midwife, you can still have your doctor and your obstetrician, and you can still have your partner. So, a doula does not replace anyone in your network. A doula adds so that you can really focus on what you need to do for yourself, focus on being in the moment with your partner as you prepare to give birth. So I think doing the research, understanding what a doula is, Google doulas in Pittsburgh, Pittsburgh Brown Mamas in that group. And, every day someone's asking about a doula. So there's definitely a lot more knowledge and understanding of what doulas are, and people are interested. There's lots of options, probably interview them to see, kind of what you want. Take some time to think about what it is that you want. A doula can help you with your birth plan, taking that next step of knowing what you want during your labor and delivery and postpartum experience. So I think now's the time really where there's just so much information out there. If anyone ever wants to call Healthy Start just to get some advice on how to choose a doula. We assign our doulas based on availability, not unfortunately, just because of the way it works, you can't choose your doula through us. But if you are selecting your own doula, interview them. Do an interview, see if, social media allows for you to kind of get a feel for personality. There's a lot of doulas that do a lot of virtual free birth education so that you can kind of get a feel for what a relationship with them might be like. So I think there's so much information out there and resources and places to go if you need to know more information about how to connect with doula services.
Thank you, Ms. Sherrill. Dr. Braxter, did you want to add anything?
No, I don't. I think Ms. Sherrill summed that up very nicely in terms of doula work, and the data suggests doulas make a difference. And we honestly, at this point, we need everyone at the table trying to contribute in order to reduce what we are facing now. I will underscore the need for all women, particularly Black women, to express their expectations when they are with a provider. What do you expect? How will we deal with differences? Because that will occur. How will that be handled? Because we know when there are differences between providers and clients, we may not get the best outcome. The data has shared with us that. So that is something that we can encourage all our birthing persons to share expectations, share desires with their healthcare providers and others as they move forward in the perinatal and maternal health arena.
Thank you, Dr. Braxter, and thank you, Ms. Sherrill, for your participation on this awesome event today. I do want to leave just a minute here to see if there's any questions that any of our listeners have. If you could submit those in the chat at this moment. We want to make sure that our panelists address those. I do know and want to thank our nursing students who I know are participating today as well. So thank you all, as you all are our future healthcare workforce. I want to thank all of those who are just here because they wanted to learn more and be more active in the community and supporting those that they love. Today, I think we've learned a lot from the Maternal Mortality Review Committee and its importance and the impact it can make in our communities. We learned a lot about the Omnibus legislation, which was new to me. So how we can get involved and get our policymakers involved as well, and really making sure that the health and wellness of our community is at the forefront. I think we want to make sure we leave with each of our participants about the Hear Her from the CDC, as well as the post-birth acronym, about really making sure that we know what are warning signs and where people need to seek information and health about during pregnancies. Ms. Sherrill shared with us about the Healthy Start and all the work that is happening. And one thing I highlighted, Ms. Sherrill, was that it is not income base for our Black women. And I'm going to tell you that was something new that I did not realize as well. So please, 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 if you haven't learned anything else in this presentation, remember that, and remember that there's resources out there. And so I think it takes an entire, as we said in the beginning, it takes the entire healthcare team really working together to improve the health and wellness for our community. We want to thank everyone who has participated today. A huge thank you to Gateway Medical Society for all of the years of dedication in improving the health and wellness of our community. Pittsburgh Black Nurses in Action, you guys know how I feel about you and the work that we have to do, and we know the work that is definitely in front of us. And we want to thank all of those who participated today. If you have any other comments or anything, please make sure you can get a hold of Gateway Medical Society through their website, or Pittsburgh Black Nurses in Action as well through our website. And with that, I think we will end our presentation, but I just wanted to say thank you again to our panelists.
Thank you.
Thank you.
There was one question in the chat that came up at the end, if we can just make sure we answer their
Oh,
question.
I'm sorry. I did not see that as I was looking through. Okay, sorry. We have one question on there. How does a concerned community member participate in MMRC?
So part of the participation is if you'll let me know, and I'll give you my email address right now, or I'll put it in the chat. Then I can bring that forward to members of the MMRC, and they may get back to you. So I'll put my email in the chat, and please, we do need the participation as we move forward, particularly in terms of if the lived experience, that's what we need, those individuals on the committee. Thank you.
Thank you, Dr. Braxter. Any other questions in the chat?
I think that's it. Thank you.
Okay. Well, thank you all, and thank you for the participation, and thank you, Gateway Medical Society, for really leading this discussion.